Okay. I don't know what happens after we record it, how to get it back, but I'll find out. All right, let's see. I'm Sarah Martin. I'm a child and adolescent psychiatrist. I also did all my training in the military. So I'm a former military psychiatrist, now a child and adolescent psychiatrist. And I have been very happy in this specialty. I love working with the entire family. One area of interest I have is working with primary care providers. So there's an extreme shortage of psychiatrists. And so a lot of times people don't get treatment. Plus, there's stigma associated with actually going to visit a psychiatrist, as I'm sure everyone knows. And so the idea of working with primary care providers is that if you can help them become more comfortable managing their less complicated patients, then there will be more slots with child psychiatrists to see the more complicated patients. So right now we're working on a project called the Child Psychiatry Access Network, and it's going on all over Texas. I'm helping to manage the El Paso hub of the project. And we now have a hotline you can call anytime from 7 to 4 on business days to have a direct consultation with a psychiatrist. So it's a peer-to-peer consultation line. So when you guys are on your rotations and you like say you're on family medicine and the patient comes up with, especially if it's a child, but I'm not going to turn anyone away if you know, you can call up and ask me like what medication you should start, what symptoms you should be looking for, that sort of thing. One of my other interests is in suicide. Very interested in which the the $100 million question in psychiatry is why is the suicide rate going up? It's been going up for the last 20 years, and it's probably higher than it's ever been in recorded history. So that is a very important part of psychiatry that I'm trying to make inroads, but I'm just one person, but that is kind of my academic interest. And I am, as part of our state-funded projects, we have 2 research projects, one having to do with childhood depression, and the other one having to do with childhood trauma. These are directly funded through the state budget, so they're very conservative in terms of they don't want to do anything too intrusive or invasive with the state's children. So they are projects that are really following the natural course of depression, suicidal thoughts, and childhood trauma. And they're including both one-time traumas as well as ongoing trauma, such as child abuse from parents, that sort of thing. So those are 2 studies that are active right now. We're just getting started, and those are some of my interests. Dr. Raheb is next.
Okay. My name is Mata Saragib. Mata Saragib. I'm a psychiatrist, general psychiatrist with special interest in trauma and graduate medical education. I'm the program director of the new residency program at Trans Mountain. We're doing the interviews. We've been doing the interviews for a few weeks now. We're almost done, and hopefully we'll be able to get very good candidates. We place high priority on foster students, so think about it. The main clinical interest is PTSD and other trauma-related disorders. There are a few things that kind of caught my attention early on. Another $100 million question is, why do people develop PTSD and others in the same situation don't? The idea about resilience and whether resilience is actually possible. Can you develop it? Can you teach someone certain behaviors and techniques so that they become more immune to trauma? Hopefully they're not going to use this in war. I'm against war in all shapes or forms. Sorry, Sarah. But one thing also, the second thing that was established many years ago in the National Comorbidity Survey, we always thought, at least I thought, of trauma-related problems as a preventable disorder. Like, you know, someday some people will not be exposed to trauma, will not get abused, will not get injured, will not get mugged, etc. That's not going to happen. In fact, the National Comorbidity Survey showed that it's the norm that each of us gets exposed to a traumatic event by the diagnosis itself. So we're not talking about regular, you know, I cut my, I don't know, had the paper cut. We're talking about witnessing someone getting seriously hurt or dying. So we will get exposed. And it seems like the norm evolutionary is that we heal, we recover. Most people do recover, some don't. If you think about it, you know, evolutionary, early man must have had some trauma or another, whether from a guy who wanted his wife or the wife upset with him, or now, you know, that's kind of misogynist and talking about the man only, but the man was probably getting hurt more often as they hunt for food. Anyway, so these are the two things that caught my attention early on. But my interest in trauma involves working with patients primarily more than anything else. Research is important, but it's sort of a side activity. Right now, we're doing a small project on PTSD symptoms in primary care. I have a medical student working on it. Her name is Shannon Tung, and she actually applied for a grant from the American Psychiatry Association, and she won, which was a big deal. It's not something easy, and she was a first year when she did that. She's a second year now. I don't know if she's here today. So anyway, it's an exciting field. Unlike what people think, it's quite rewarding. People do improve, do recover, and it's really, really heartwarming to see someone getting out of a rut and going on with their life again. Questions, thoughts?
Okay, can I add something? Because we are just mentioned a couple of specialties, but the psychiatry is so broad because you have, for example, addiction. Psychiatry that they specialize in treatment of substance abuse, either in children, adolescents, adults, is another specialty that you can go. We have forensic psychiatry, and this year last year we have a new faculty that she did the training in forensic, and you're gonna have more opportunity to learn from her during the rotation. It's a different specialty. With also you can work with children and adolescents, maybe in a detention center, or you can do some kind of competency evaluation. Forensic medicine is a different field. Then you can decide that you work with older population, and it's geriatric psychiatry. It's another specialty that you can train yourself. Most of the fellowship the duration is 1 year. The exception is child and adolescent that you have to do 2 years of training. But there are different opportunities for you to decide where to go. And the same for the residency, because we have some combined program, either internal medicine and psychiatry, or you can go to psychiatry. There are some programs that combine psychiatry and neurology, for example. There are not too many, but this is something that you need to start thinking about your future and how you want to find your area that you have having some passion for that. Which other specialty are missing? We mentioned psychosomatic medicine. Then you can decide to go more to public health in psychiatry. There are some programs also with public health. Again, there are multiple different aspects of psychiatry that they are very important. And one thing that I really recommend to all of you now that you are starting your interest is start searching in the American Psychiatric Association, because there's a lot of resources for medical students, and the sooner that you start learning and involving, you can learn more, and there are several opportunities. And we have last year medical students that ended up having some award from the American Psychiatric Association, doing a kind of rotation. I remember one of the students, they want to neuropsychiatric manifestation of HIV. We have another student that was awarded with some scholarship in substance abuse. And so there are a lot of resources for you guys to start exploring. And it's a very good site to start learning about psychiatry.
Can each of you just tell us what was your post-residency path into your specialty? So I assume that everyone just in general psychiatry residency, and then what?
Let's see. I trained at Walter Reed Army Medical Center. It was a great residency. I loved it. It was a big one. We had 16 residents in my class. We rotated all over the National Capital region, and then we'd also do rotations at different Army bases all over. And then if you want to do if you're in the military and you want to do a fellowship, then you and I don't know if anyone of you all, do any of you all have a military scholarship for medical school? I don't know. Oh, Jay, do you have one? I didn't know that. Oh my gosh, I can't believe that. I didn't know that. What service are you going into?
The Air Force.
The Air Force. So the National Capital Region, it's a combined residency where it's Air Force, Army, and Navy. So I had colleagues from all three services. Of course, the Marine Corps, they don't have their own medical service. It's provided by the Navy. And we did great rotations. It was similar to our program in that sometimes we went to civilian hospitals as well. We went to the state hospital in Virginia. We went to a substance abuse clinic for adolescents in Annapolis. So we did a lot of driving, but it's a great residency. You should go there. And when I was at Walter Reed, they didn't let you do the combined child plus general psychiatry in 5 years. So that's one thing to know. You can either do 4 years, general psychiatry is 4 years, and then you can do child psychiatry for 2 years after that, or most places will let you start after your second or third year and do child, and then for a total of 5 years, 3 years of general psychiatry, 2 years of child psychiatry. So when I was at Walter Reed, they didn't allow that. So I did 6 years. I did 4 years of general and then 2 years of child psych. I got into it kind of by accident, into child psych kind of by accident. So I was a senior medical student, a fourth year medical student in 2001, a very, very traumatic year for the United States Army, certainly, and for the country. So as when I joined and accepted my Army scholarship, I thought that Bill Clinton was president. We hadn't had a war in forever, and the one we did have was 3 years long. So really, nothing had happened much since Vietnam. And my father had been in the Navy. He joined right after Vietnam and retired right before anything else happened. So we had a very different career. So anyway, 2001, I'm about to graduate in 2002, and the Twin Towers happened, Pentagon, 9/11. That really changed everything. And so when I was a third year resident, I had a baby, and in the military, usually, at least in the Army, and they have longer deployments in the Air Force. The Air Force they take very good care of their doctors, so that's a good choice, Jake. So in the Army, as soon as you graduate, they deploy you if they're having, if they need you. When I was in, the whole entire time I was in, the war was pretty full strength, both in Iraq and Afghanistan. And so I was my baby then, she's turning 16 tomorrow, but my daughter was only going to be a year and a half when I graduated from general psychiatry. So I'm like, oh, dang, I better sign up for a fellowship. And, the whole time I'm in residency, everybody's thinking, oh, the war will be over before you graduate. Everyone's, oh, yeah, it'll be over by the time we graduate. No, not at all. And still not over. Somehow that still is not over, but that's another story. So anyway, the longest fellowship is child psychiatry. So they're always looking for child psychiatrists. Even the most popular programs have Harvard fills, okay? Harvard and Yale, they fill. But even some university in California programs don't fill every year. Just not enough people going into child psychiatry. I think part of the problem is you have to do general psychiatry at least for a couple of years before you can go into child psychiatry. That's one of the problems. But anyway, it's always short. So they're always recruiting, and so they talked me into doing the child psychiatry residency fellowship, and I was actually very scared. I thought it was very difficult to deal with the whole family. And now that I've been in child psychiatry for so many years, actually, I think it's easier than regular psychiatry because you deal with the entire family. So it's interesting because what some people think as a negative, I think most people that go into child psychiatry end up viewing it as a positive because you have an advocate with that child that lives with them all the time. So your patients if you can get the family on board, then you have somebody who can help the patient, even because you might only see the patient once a month or once every 3 months. But if you can get the parent on board, then that child's being helped pretty much every day. No parents helps their child every day, but even the best parent. But so that's one thing to think about when you're in child psychiatry. Don't be scared by the families. That's one of the skills I think that you learn first in child psychiatry. And once you've learned it, you've got it, and it's not difficult. And I've had an amazing career. I've done so many different things I never thought I would do because I was in the Army, but then also because I ended up here at Texas Tech in academics. I can't encourage you enough to do an academic career. If you go into clinical medicine, it's from day to day, things can be very similar. In academic medicine, there are no 2 days alike, right, you guys? Every day there's a new challenge, there's a new project. There are just so many different ways your career can go. So anyway, that's a little bit about a very long answer to the giant short question.
So the question for the other two panelists, what was your path after residency to your specialty?
Want me to go, Dr. Reddy, or? All right, my path is a little bit weird. Right? So I finished my residency also in Maryland, very old hospital called Shepherd Pratt Hospital, with partnership with the University of Maryland. Again, it's a very big program. I think we had a total of 70-something residents. Great training. After that, I moved to Providence, Rhode Island. I was with Brown for 7 years. Then decided to kind of change the the path a little bit. And I worked in the private sector with Kaiser Permanente for a year, which was really interesting. You might or may not know about them, but their model is that they have everything in one place. So they're the insurance company, they employ the doctors, and they prepare the place and venue where the doctors practice. And they were the first people to apply this medical home model of care. But anyway, it was good, but the problem, as Sarah was referring to, is that private practice, it can get lonely. It may not be boring, but the routine every day involves you doing your daily practice, and that's it, nothing else. And I found it very hard to kind of endure. Anyway, so at that point, I had out of the blue offered to help accredit a program in the UAE. The ACGME has started accrediting international programs, and one of my mentors nominated me. So I went, kind of an impulsive move, but you do that sometimes. We did what we needed to do. We had the program accredited twice. I was there for 4 years, and then I came back to this job, which involves being the program director to the basically forming a new program, and of course the rest of the academia, the research, the clinical care, and teaching. I'm not suggesting that you do the same. You don't have to move that so many times, but definitely if you do, make sure you research what you're going to very well, and prepare to stay at least 3 or 4 years. Anything less than that, then you just wasted your time. And people were wondering, we're always wonder why. Graduate medical education is a great unexplored subspecialty in medicine in general and in psychiatry specifically. There are many new challenges that keep emerging, especially in the evaluation field. And it's not very well known to the rest of the medical community. They think that residents go into the training program and they come out, and that's it. What happens in between, everybody will graduate, everybody will learn, and everybody will be the same, which is not true. But it will take some time until people kind of realize that it's a little bit more sophisticated than that. Yeah, it was an exciting career. Sometimes exhausting, but exciting.
Okay, it should be my turn. Okay, if Dr. Rahevki said that his career was unconventional, you need to hear my career. As you can realize, I'm a foreign doctor, an original from Argentina, and I did my training in Argentina in neurology, and I was a professor in neurology in my country. And one day with my husband, that is a physician, we decided to come to US to do some experience, to learn more research. And of course, we really like this system. And I need to, in order for me to continue be practice as a doctor, and I have to retraining. And I decide, instead of repeat the neurology residency, I decide to go to psychiatry, because I always having some interest in psychiatry, and psychiatry in my country was not very well developed. So all the underdeveloped country, they don't have too much interest in psychiatry. And when I came here and said, okay, I really have some interest, and maybe someday I can put the two specialty together. And I decided to train in psychiatry, and then right now I have the specialty in behavioral neurology and neuropsychiatry that you can combine both. And the other aspect that I really like, and I'm an academician, I was teaching in Argentina, I was teaching here, is develop the career teaching resident, teaching medical student, that of course private medicine, you cannot do that, at least 100% that we are doing here. And I really have a passion working with you guys, because we are learning with you, we are learning with the resident, and we are better in the thing that we are doing every day. I really enjoy my daily work, and this is something important that you need to find out, because they're going to be challenges in life, but if you really like and you have passion for the thing that you are doing every day, you're going to take all the challenge. and my retraining here in US was not easy, because also I was having children and you need to balance, and in a foreign country, but I did my training and working full time now. It's a different pathway, but I really enjoy what I'm doing every day. We can hear your question. We are talking too much.
Are there any cons of your specialty? And I guess if you can't think of any, what is the most challenging aspect of the population that you treat?
Okay, in psychiatry, we have challenged patients, either in children, adolescent. In adult is more complicated, because we are having, in most of the cases that Dr. Raquel was mentioned, some history of trauma, the way that the patient was coping in most of his life, and sometimes we have some combination of trauma, substance abuse, very dysfunctional family, is a combination. And when you add some neurological problem or to all these aspects, they really, you're going to find some challenge patients. But in general, I'm going to say psychiatry is very challenging. Think about yourself. A human being, they are very complex. And sometimes you don't understand yourself, some reactions and impulse behavior. Can you imagine when you are dealing with some schizophrenia, some mood disorder that make everything more complex? Being in psychiatry is challenging, but at the same time is very rewarding. And the reward that we have sometimes is a smile, seeing somebody smiling. If you want to have a more reward, go to obstetrician. This is a different specialty, that most of the cases they're going to have a good result. In psychiatry, sometimes it's hard to see big improvement, but developing a good relationship with patient, seeing the patient or the family getting better, getting more stable, is very rewarding.
I think the thing that drives me the most crazy about psychiatry is in all of medicine, and that's insurance companies. So insurance companies allow our patients to be seen and get health care, and they drive the doctors crazy. So they absolutely are necessary. But it is, to me, that's a kind of annoying thing about any type of medical specialty. I think in psychiatry, one of the things that is important to recognize, even when you're a student and even when you're a resident, is what kind of patient challenges you the most. Most people find that there is a certain type of patient, and sometimes it's a patient with a certain diagnosis or a certain personality type or certain coping skills. But there's usually a common theme there. And you always have to be on the lookout for what type of patient do you get the most annoyed with, the most upset with. because those are the ones that are going to be the biggest challenge. And it's important to recognize what type of patient that is so you can work on it. You can work on it with your supervisors and sometimes, you know, in the military, we had training psychotherapy. So that's what we would discuss, those types of issues, the interpersonal issues between the doctor and the patient. But so everybody has those sorts of challenges, but that's probably common to most specialties too. I think people with borderline personality disorder, they get a bad rap. And I remember when I was a resident, one of the social workers said, "Oh my God, I just cannot work with patients with borderline personality. I can't stand them." And my first thought that popped into my head was, how can you be in psychiatry and not want to work with patients who have borderline personality? Because they are a group that really needs a lot of help. And the better you can, or the more that you can learn about how their minds work, the better you're able to help them. And if you're annoyed with someone or you're feeling sorry for somebody, you're not really going to be able to help them. So understanding yourself sometimes is one of the biggest challenges.
I understand the question as well as you're saying the cons, maybe the downsides of the specialty, if I understand correctly, Jay. Clinically, there isn't really a downside, right? There are certain patients that are harder to deal with. There are certain clinical situations that are more difficult than others. Some patients will get attached to you too much, and if you're not well trained, you can get in trouble. The personal factor is definitely something that needs specific training. Either way, so you may get really annoyed by a certain behavior from a patient, and in that case you're probably mixing between dealing with the behavior in the general public, right, someone who's a jerk, and then but the same person when they behave not exactly in a courteous way with you in the clinic, your perception and management should be completely different. But it's hard, and this needs training and guidance in during your residency specifically. The real, well, I don't know if it's the real, but it's definitely, there are a few vulnerabilities in our specialty. The first one is that we almost detached from general medicine at some point. We were almost taken away completely from being a medical subspecialty. And I think going back after that took some time and pushed us behind a little bit from the rest of the medical specialties. That was the time of the era of the golden era of psychoanalysis and psychodynamic psychotherapy. Luckily, at the same time, medications were discovered and the whole course changed. But we're still vulnerable. So, for example, when insurance companies started cranking down on medicine in general, it was hard for them to argue with procedure-based specialties because, you know, it's a fractured femur. What is it? There's nothing there to talk about. It needs to be fixed. But with our patients, things become a little bit more murkier and 100 shades of gray. So there was room for insurance companies to start denying service, to start refusing to pay or refusing to have the patient cover for a specific management or if a specific frequency of visits, because they're telling you, they're saying, well, you proved that they need that. And that's not an easy job. And this is not something we often, you know, pay attention to. We're busy trying to help people get better, not make sure that the document is fitting with the insurance requirements. Things are getting better because the society as a whole is recognizing more and more that this is a really necessary specialty, and if we want to keep them, we need to have better treatment, and we shouldn't be leaving them up to the insurance companies like that. The models for care that would get us away from their influence is it's a little bit longer discussion, but it's happening, so which is good. In other subspecialties in psychiatry, for example, addiction, this is another vulnerable area that everybody can say what they want about what works and what doesn't work and what should be funded and should not be funded. It's kind of, because it's so pervasive and gets into the life of everyone, and it involves a human behavior that's been criminalized at some point. So now everybody has an opinion, and some will have more than others. Religious figures tend to have lots of influence. Sometimes we agree with them, a lot of times, but sometimes we don't agree when they start discouraging patients from taking medications, or saying that psychiatry as a whole is a bogus specialty, and we hear that. It's hard for them to say the same thing about cardiac surgery. Very, very concrete, specific things to be done. So for you to manage our specialty, you really has, I think one of the people that I heard one time, you have to have some degree of tolerance for ambiguity, right? Things will not be black and white, and if you think they are, and really not willing to kind of change your mind on that, it's not going to work. It's definitely not going to work. I understand the question is about cons, but one major advantage, I was just talking about that to a young medical student the other day, there are no two patients alike. It's not happening. I've been doing this for almost 20 years now, and I'm still seeing people as if I'm doing it for the first time. And the more you see patients, the more you start to encounter those who don't fit well with the diagnostic categories. We try to stay away from that because it will kind of, sometimes it will influence the treatment decisions negatively, but in general it does happen. And it happens with enough frequency that it becomes kind of an exciting thing to find a new mystery to solve. But anyway, so that's these are the things that kind of to watch for. If you like to work with your hands, sorry, there's no hands here. Psychoanalysts actually forbid us from touching patients, not even shaking hands or tapping a shoulder, because that would interfere with transference. That's a different story. We don't do it that way anymore, but most of us at least. But still, you really have to have some joy about working with your mind, and some enjoyment of literature, reading, some philosophy, not a whole lot, and take it away.
And my vision is maybe a little bit different, because now, and you are very young, you're going to see a lot of progress, because we know more about the brain with neuroimaging, with genetic. Now we have more neuromodulation. I'm seeing the psychiatry maybe toward a little bit more to the neuroscience. And
That's true.
To give you some example, for example, in somatization. Now in somatization, there are some patients under functional MRI in the brain. You can see some changes and say somatization is not functional. And for that reason, they change the name to functional and say the brain is so mysterious in the way that they're acting, and we are knowing more. And you guys, with all the technology that we have, probably you're gonna happen in different position compared with us, because the technology, especially neuroimaging and the neuromodulation treatment, we have some new resources to treat patients that we didn't have in the past. I'm saying that they're very exciting time for neuroscience, and psychiatry is part of the neuroscience. And this is advantage. I always see the advantage, not the difficulties.
Okay. Can you all tell us how to become, I guess, a competitive applicant for psychiatry residency programs?
Can you say that again?
Oh,
I can barely hear you.
I said, how can we become competitive applicant for psychiatry residency?
Oh,
So the first thing you got to do is pass those boards. You don't have to get the best scores in the world, but you got to pass, and hopefully you pass the first time. Don't stress yourself out too much. If you pay attention every day, hopefully you'll pass. But that's for any specialty. I think in psychiatry, I know when I was the program director, and I still, of course, do interviews with with both programs that we have. We have 2 residencies by now. I don't know if everybody knows Trans Mountain and the first one, the regular one. I don't know what to call it now. Trans Mountain and the other one, I don't know. But we're looking for people with good social skills because we need them to be able to connect with patients. I think that's one of the most important things. The other thing we're looking for is we're looking for people who are humble. We're looking for people like Dr. Tonorelli, who can, after she's been a neurologist and a professor, can come back and do a residency and learn and not think they know everything already. So those are the sorts of people that make our job a wonderful job. Some people come in and they think they know everything, and that's a real turnoff. So be careful about, everybody. A lot of people think like, oh, I have to be confident. Yeah, we want you to be confident to be able to have a conversation with strangers you've never met before. But we don't want you to be so confident that you don't listen to teachers and you don't learn from the patients. So we're looking for people who really, really want to learn. But social skills is an important thing. And I think the interview is one of the most important parts of getting a psychiatry residency. What do you guys think?
well, if you guys decide to apply to whether the Alberta or the Trans Mountain program, then that's your best chance, because we like to hire people whom we know, because that's the only predicting element. So if you've been here for a number of years and people say that this is someone who is humble, hardworking, smart, gets good grades, knows how to deal with people, that's enough. We can take it from there, right? The problem with any other applicant from anywhere, unless we know someone who knows someone, is that they're kind of a closed box. We have no idea what's inside, and unfortunately, sometimes we discover unpleasant surprises later on. Doesn't happen that often, but it happens sometimes, and it's painful when it does. So, in order to be competitive, you really want to show us that you love the specialty. You love to work with people. You love to think about things. You love to observe and watch people's behavior and thoughts. Um, you're able to engage at an emotional level um, without compromising your own. And of course, there has to be some evidence that you like the specialty, right? So, have you done anything extra in addition to what you're doing in medical school? Any research projects? Any presentations? You have to show us that this is really something. So, for example, sometimes we get applicants who loves the specialty and would like very much to be a psychiatrist, and all the CV is about molecular biology of cancer. Okay, well, I'm not saying that that's necessarily a bad thing, but maybe applying to an oncology residency may be more relevant. So that definitely is an important element to show us that some evidence that you like what we're doing.
Sorry. On that note, can you?
Well, one thing that I can add is you have the advantage now when you are coming to the clerkship in the third year and you have elective rotation in the fourth year that show that you are having an interest in psychiatry and show that you are a hardworking student. And not only if you want to stay here, if you want to apply outside, you're going to get some good letter of recommendation from the people in the department. And it's something very important. To give an example, Harald is one of my mentees, and he is doing a great job in some project that he did. Of course, he's going to have a very good letter of recommendation, either if he wants to stay here or apply to another resident. But it's a very good way to develop a good relationship with the mentors, especially in the area that you want to work. Sorry, my kids are coming back and forth.
You mentioned research. I just wanted to know if you know of any like ongoing research or outreach projects that are seeking any medical students, or who we should contact to engage in any of those.
I'm gonna recommend now. We did a very good job updating the website in psychiatry. When you go to Texas Tech, look for department psychiatry, and you're gonna see the faculty, the main areas of interest. I'm gonna recommend to email the faculty if one area that you like more than the other. We have the brain bank, Dr. Gadat. She's in charge of the brain bank, and always they have some opportunity for research. And say, look in the website and contact the faculty. And usually research is team. It's a team. You're gonna work either with some resident, with some faculty in the area that you are looking forward. But I'm gonna say starting looking to the website that is brand new, very updated, and you can find some interest over there.
There are a couple of big projects going on now. Dr. Martin alluded to them already. The SP11 funded projects. So these are huge endeavors, and there's always room for people. So if you would like to join the depression arm, then Dr. Martin is your contact. For the trauma arm, then Dr. De Vargas is the one in charge of the other one. What I can tell you about our side of town is our main interest is clinical research. So as I was just telling you, one of the projects that had this award was about trauma symptoms in primary care patients. So we're doing this in conjunction with the family medicine department. Another one is also going on is about female sexual dysfunction, also in primary care. There are other ideas that myself and Dr. Lopez are thinking about. And we're always looking for good people who would like to work on interesting subjects.
Okay, and then my last question, I'm not sure if anyone else has any questions. I know that Dr. Tony Rowley usually advises fourth years with their scheduling. Are there any other, should we just reach out to the other faculty, as you said, like through their emails? Okay.
Yes, definitely. Most of the faculty in psychiatry are working with medical students. We have Dr. Delgado in the area of substance use disorder. Dr. Ortiz, she is the assistant of clergy director. She's working in forensic. We have Dr. Rajev, Dr. Lopez, Dr. Martin in child and adolescent, Dr. De Vargas. Most of the faculty are are working as an advisor, depending your interest. The easy way is contact me, because we trying to set up the rotation as a MS4, be sure that there is no conflict with the interview season, because if you want to do psychiatry, I want for you to be sure that you want to have the rotation before the interview season. Is the way that the people in the department going to know more about you, and you're going to be prepared for the interview. However, any faculty could be your advisor. I really encourage you to start contact the faculty sooner than later, because all the faculty can give you different ideas, how to do this one, how to involve in some community activities, research. It's always a good idea to contact the faculty.
Did any of the other students have any questions that weren't answered?
Hopefully they continue having interest in psychiatry after listening us.
Yep. I hope so. You guys are a quiet bunch. Oh, here we go. What are some major conditions managed in each subspecialty? Let's see, for mine, of course, we see ADHD, although a lot of that is managed by pediatricians. Depression and anxiety are the most common besides ADHD in childhood. We see PTSD, we see DMDD. Usually we have a lot of kids that end up being referred to us because they got in trouble or behavior type problems. The externalizers get sent to the psychiatrists sooner than the internalizers. What about you guys?
Well, the most common in the adult clinic in any case, outside substance abuse, is depression. So these are the most common patients that we see. If you work in a more urban area, you'll find the number of anxiety patients really high.
Yeah, in neuropsychiatry, of course, depression and anxiety is very common. However, we have a lot of cognitive problem. Patient with cognitive problem, also related to comorbidities that they have, and this is one area. And we are seeing also adult patient with intellectual developmental problem, with some behavioral problem, impulsivity, sometimes comorbidity with ADHD, epilepsy. So it's kind of complex, the different presentation. However, depression, I agree, is probably the number one.
And for those of you that are really interested in psychotic disorders, schizophrenia, and severe bipolar disorder, inpatient psychiatry is something you might want to think about, or public psychiatry, working at a community mental health center. There's in every county in the country pretty much has a mental health center that really focuses on, they call them the severely mentally ill. And so if you're interested in those really severe disorders, that would definitely be something you would want to think about. And we are adding a rotation starting this week at EHN for the residents are going to start first, but I think eventually they're going to have medical students too. And it is going to be in a clinic with young adults. And schizophrenia is a young adult's illness. That's when it presents. So it should be very interesting. But the community mental health centers also see those people that don't have insurance or are underinsured, that sort of thing. People that have Medicaid, that are disabled. And so that's a very interesting part of psychiatry.
Okay, so there are no more questions put in the chat, so I'll assume that there are no more questions. Thank you, Dr. Martin, Dr. Rahib, and Dr. Tonarelli for your time. And we're
Thanks
still
for inviting
you.
us.
Thank you. Thank you for organizing the event.
Yeah, and Dr. Martin, I'll reach out to you to make sure that we know what to do with the recording.
Okay, all right. I guess I'll stop recording and maybe it'll ask me if I
Want to
save
save
it somewhere. I don't know. We'll find out. All right. Well, thanks for coming, everybody.
Thank you. Thank you.
Take care.
Thank
Good
you.
night.
And remember, in the website, you have an email address. Bye.
Did you want to try?